I think there is another award session here immediately after this. So any questions, we will take it at the end of all these presentations. We have 4 presentations. We'll take it at the end of the presentation. So for the next 15 minutes or so, I thought I will just discuss a few important practical aspects of how to route tubes into positions of adequate anterior chamber depth, some practical tips about sulcus placement of tubes, and also what to do if you're planning a repeat tube. So Neetu had already shown this, and this has become one of my most favorite slides. You have to be working around this 2.83 millimeter distance from the tip of the needle when you change the position into the... You're not hearing?
Volume is low.
I think I need to shout then. You are not hearing, Moiti?
It's low hearing, sir, but it's very low.
You should find ways, device ways to see that the tube is placed as close to the iris as possible. So this is a patient who had a lot of anterior pass. There was no way we could have placed the plate has been placed in the supratemporal quadrant, and that of course is the most preferred quadrant of choice for placement of an episcleral plate of any glaucoma drainage device. And it's only about much far away from the original position of the tube that we have adequate depth of the anterior chamber available for a safe placement of the tube. So this was already shown. So initially it is parallel to the sclera. You just advance it forward, and a particular predetermined place you change the plane of the needle entry to iris plane parallel. Initially it is parallel to the sclera, so you get into the anterior chamber at a safe distance away from the endothelium. So now the difficult part is how much of the tube do you trim to get an optimal length of the tube in the anterior chamber. So this is also very important. Once before you mark the tube, it's important that you push your episcleral plate back so that it is in its original position, where it has to be about 9 to 10 millimeter posterior to the limbus. So by trial and error, we found that if you mark the tube about the distance, if the distance from the scleral groove which you fashion, and that distance from the tube should be the distance of the tube that you trim, you get an adequate length of the tube in the anterior chamber. This was about 6 millimeters away from the tube. So we have trimmed the tube 6 millimeter by draping it over the cornea anterior to the limbus. We drape the tube and trim 6 millimeters, make a good anterior bevel, and you place it into the anterior chamber. You get an optimal length. This always used to be an issue because sometimes we trim it too long, too short. So if you trim it, and you can place an additional tube stabilizing suture there to make sure that the tube, the extended length of the tube lies flat on the sclera. And ensure that you have adequate tenons and conjunctival closure. So this is what I was mentioning. Drape the tube over the cornea and trim the tube to a length equal to the distance of the tube from the scleral groove fashioned for tube entry to optimize tube length in the anterior chamber. So this is about 3 months post-op, and this is late post-op, and these are especially useful. This is 4 years post-op, especially useful in accent field rigor, eyes syndromes, and other patients who have a lot of anterior pass. So ensure that you route tubes into positions of adequate anterior chamber depth. Coming to sulcus placement of tubes, it's quite easy if you have a lot of anterior pass at the supratemporal quadrant where you're planning to insert your tube. Especially in a post-PKPI, you see a lot of anterior pass. In many patients with neovascular glaucoma also, the iris is tented up. It's quite easy. Again, try to find out areas where you could take advantage of. This first patient had seems to have a sphincterectomy there. This patient had a peripheral iridectomy through which we can put in the tube into the anterior chamber. And also in uveitic glaucomas, there's a lot of posterior synechia. The tube is plastered onto the PCIOL. see this, this is another video where there is a lot of anterior pass, and we are planning to place the tube in the sulcus. So this is 2 millimeter medial to the original position of the tube. And you might have to make that transition a little earlier, but if there's a lot of tenting up of the iris, there's not much of difference between your insertion into the anterior chamber and also into the sulcus. I just put up this video just to show the practical difficulties we might experience on table. So because it's a very sharp needle, you are able to get it in between the iris and the PCIOL. But again, the iris is totally plastered there. Taking back the needles from the anterior chamber is also extremely, you need to be very, very careful. You need to ensure that the track closes it's on its own while the needle comes out. You should ensure that your second hand should not be applying too much of pressure on the globe, where a lot of aqueous gush can happen. Again, another important tip, if you want the tube coming into the sulcus, going into the sulcus and coming out of the pupillary border, you need to measure the length of the limbus from the pupillary border. If you measure the length of the limbus to the pupillary border, and if you trim the tube at that particular position and then you route it 2 millimeter medial, you can ensure that you get an adequate length of the tube in the anterior chamber beyond the pupil. And this is something you will definitely experience. This tube doesn't go into the sulcus. Even if you have a good anterior bevel, there is this posterior synechia there onto and usually a cyclodialysis spatula usually will help. But this was an extreme case where there is so much of, I am trying to get into the anterior chamber. Because of this anterior pass, there's an inadvertent iridodialysis there, a small iridodialysis. Luckily, it didn't bleed. Trying it another side, because all over there is pus. I'll just fast forward it a little bit. So much more anterior small paracentesis, and trying to get the tube into the beyond the pupillary border in the sulcus. So once you have the needle entry in the correct position in the sulcus, it still we may not be able to really get the tube into the anterior chamber. You just keep pushing the tube, it just tenses up the iris. Finally, we needed help from iris retractors to get this tube into the sulcus beyond the pupillary border. 2 iris retractors pulling the iris up, and then but this is an extremely rare case. Usually with this kind of movement, with this manipulation of the cyclodialysis spatula, usually we are able to get it into the correct position. So that was the post-op. Luckily, the patient is doing well as of now, but with this much of anterior pass, you never know when the cornea is going to start decompensating. So another important tip here is drape the tube over the cornea and trim the tube to a length equal to the distance of the pupillary border from the limbus. That is the original position of the tube, and then route it 2 millimeter medial. You will get it in an ideal position You could also plan to leave the tube bevel down behind the iris, provided you can visualize the tube tip in the dilated state in sulcus placement. Coming to a failed GDD, what are the things that you need to keep in mind when you need to plan for a repeat tube? So the most important thing is prefer the superior nasal quadrant as your second quadrant of choice for implantation of the second GDD. And the surgery is exactly the same as what Neetu showed. It's just a mental block. You just sit on the slightly towards the nasal side of the patient and think that you're working supratemporally. Everything is the same. The problem occurs when you have a failed tube supratemporally and you have multiple surgeries by the vitreoretinal surgeon, and you have these staphylomas in the supranasal quadrant, and you will have to plan for an infranasal tube. This becomes challenging, far more challenging than a supranasal implantation. I think I'll just, the plate implantation is the same as what Neetu showed. Actually, the infranasal and the supratemporal quadrants are completely devoid of these oblique muscle tendon complexes. So it's extremely easy, and patients also very, very rarely complain of diplopia if you're working on these two quadrants. It's the same. You identify the medial rectus and the inferior rectus, and you place the episcleral plate adjacent wings beneath adjacent rectus muscles. Only thing is, every time you handle tissue there, make sure you handle the tenons, and even if you give the tenons to your assistant, make sure that the assistant holds the tenons. It's very, very important. Also, for suturing these episcleral plates in the infranasal quadrant, sometimes it's useful to hook a particular muscle, give it to the assistant, she can hold on to it, she can even hold on to Parsi, that is the assistant holding the tenons. And then you can slip it beneath the inferior rectus muscle. So now this is the difficult part. In most of the surgeries that we do, we are working away from us. And this is one area where we are planning to make your needle entry towards you. Again, 4 millimeter is little difficult. 4 millimeter scleral tracks are difficult in the infranasal quadrant. We prefer to have about 3 millimeter scleral track. Again, 2 millimeter medial to the original position. And then you make that groove that which Neetu already showed, partial thickness about 50%. And then, see, this is the length of the tube that usually my assistant gives me for a supra, but you will have to play around with the length of the tube and length of the needle and also the bend of the needle to ensure that you are, see, I have reduced the length of the tube, length of the needle, but again, the bend is not, the bend needs to be much more acute because there is this nasal bridge which is going to really compromise your hand movements there. Again, the mental calculation, where do you dip into the anterior? This is extremely, that's why each of the videos has this needle track entry. Extremely important to prejudge where you want to dip into the anterior chamber. So here, it's again almost the 2.8 because it's a 3 millimeter track. And see, at this 2.8 millimeter of the needle has entered the scleral track. You change the position into just like your keratome entry into the anterior chamber during cataract surgery to ensure that the needle gets into the anterior chamber as close to the iris as possible and away from the endothelium. This is the most challenging part of infranasal tube implantation in quadrants other than the superior quadrants. Again, bringing out the needle also has to be very slow, ensuring that the track self-seals on its own while it comes out. Another tip here, this again ensuring that the episcleral plate is positioned 10 millimeters posterior to the limbus and then marking it 2 millimeters. And another important tip is if you want to create an anterior bevel in an infranasal quadrant, you need to go underneath the tube. Always you will be trimming over the tube. This took us months and years to find out. We used to cut like this, get a round bevel and then sit and pray, and the tube just doesn't go into the infranasal quadrant in the anterior chamber. We found out that if you go underneath the tube and make an bevel, you get a good anterior bevel for infranasal implantation. It is important to have skills to manage implantation of glaucoma drainage devices in quadrants other than the supratemporal quadrant to preserve useful vision in certain select situations. Again, a few points here. 4 millimeter scleral track is difficult. Adjust the needle length bent, which I already discussed. Scissors underneath the tube to fashion an anterior bevel. Patch material left to the comfort of the surgeon. Remember, you're working towards you in the infranasal quadrant. And to summarize, if you have a failed, this is a retracted tube, failed GDD, you need to go to the supranasal quadrant. If supranasal quadrant is intact, the patient I was showing you had no place for a superior nasal implantation, and then we had to go to infranasal. And on a very rare occasion, is a monocular Sturge-Weber boy who had expulsive hemorrhage in one of the eyes, preserving vision with the third tube infranasally. Thank you.